And I think what we're seeing is more of a conversation around, wait, hold on, these health plans, employer-sponsored health plans, the plan sponsor, which is like a proxy entity for the employer, has a fiduciary duty to make sure they're paying the best rate possible.
Why do more people not know about this? Why is this not part of everybody's conversation every single day?
I think that people are not aware of it because even if you were, again, we're a software company. What is our job? Our job is to make it easy for members.
Mm-hmm.
Because what we saw was that despite hospitals having the regulatory obligation to make people aware of it, it's kind of in direct conflict with their incentive to collect balances. Hospital or provider, I want to pay you for this care rendered. I just want to know what it is, and I want to see the receipt.
Right.
And that's it. And at the magnitude of dollars we're talking, it feels like not an unreasonable request, yet the intermediaries say that is an unreasonable request, which then obviously always begs the question of like, why? What are you afraid of me just looking?
The Business of Benefits is your no BS, no sales guide to real solutions.
No gimmicks, just the truth about how to take control, transform your benefits, and care for your most valuable asset, your people.
If you're tired of the same old sales pitch and you're ready to rethink your benefits, this podcast is for you. The truth is out there. Are you ready to hear it?
Hey, Patrick, thanks for joining us today on the Business of Benefits.
Thanks for having me, Donovan.
Absolutely, man. So you and I know each other and we use your solution with our clients, our employers and plan sponsors. But give everybody a 90-second intro kind of into you first, your background in the healthcare industry, and then we'll kind of get into Goodbill and what you guys do.
Sounds good. My name is Patrick Haig, co-founder and CEO of Goodbill, based here in Seattle. I am think of me as like a software guy. That's how I got into this industry 13 years ago. My co-founder and I started software businesses. We eventually made our way to healthcare. Really, we got obsessed with maybe some of your clients have this, but membership-based primary care. It was just a very easy thing to understand of how people could just have unfettered access to primary care at cash rates and understand exactly what they're going to be paying for certain things. And that just got us wrapped around the billing and cost side and pricing side of healthcare, which is, as you probably know, really deeply insane, generally speaking. And so we've been spending a lot of time there since we started Goodbill about 4 years ago, really driving towards how do we make the cost and price of healthcare cheaper, more affordable, and easier for people to navigate and ultimately drive savings for plans and members together.
Yeah, I love it. So let's talk about kind of one of the main functions of Goodbill, and let's just start simply. What is 501R?
Yeah. So to keep it really simple, what we try to do is save people money. How do we do that? And we're focused on hospital bills. These are the big ticket items that usually hit people, especially people on high deductible plans. We're trying to basically pull out the stops on every strategy that could possibly lower their cost of care. So 501R, this is IRS section 501R. It's actually an IRS regulation, and it applies to all nonprofit hospitals. This actually came out of the ACA, the Affordable Care Act. What it says is, hey, all nonprofit hospitals, you get a tax exemption. You have to justify your tax exemption by having these types of financial assistance programs. It doesn't say how people are going to be deemed eligible or not, but all it says is that when you have somebody that applies to this assistance program that you have to publish on your website and you approve them, because the hospital's in control of approving them, you have to discount their care, or rather said differently, you have to limit the charges that they're receiving on that care. And this applies to all medically necessary or emergency care. That's like a lot of care.
Mm-hmm.
And when we talk about like scope of this applies to all nonprofit hospitals, which is the first question. Is like, well, like how many is that? It's basically 60% of all hospitals in the country. And if you look at all the hospitals in the country and you added up all the beds that they have, which is say all the capacity they could absorb, it's about 80% of all hospital beds in this country are at these nonprofit hospitals.
So this program is universal against all of those. And I know we did this recently on a proposal too, and we were showing them, and it happened to be like all the hospitals
Yeah.
in this particular area in Central Florida. But it's not only just not-for-profit hospitals. A lot of for-profit hospitals have a version of this program as well. Is that right?
That's right. Definitely the nonprofits, they have to do it for compliance reasons. But I think what's happened is that the for-profits, think of like your tenant hospitals or your HCA hospitals, they also offer financial assistance programs. They're just not required to do so. If I were to hazard a guess, it's because they're staying competitive and because they are often running into situations where people just simply cannot pay the balances that are remaining after coverage or if they have no coverage at all.
I was going to say, this might be getting a little in the weeds, but like, what would be the motivation for a for-profit hospital to do this? In my mind, it would be, one, this is a balance they'll probably never collect on. And then there's probably some sort of write-off for them if they accept it as like a financial assistance. Would I be
Well, I
correct in
think
that, or?
I think if I were, I mean, I don't know. I'll
Okay.
like caveat with I don't know how an HCA thinks about it or a tenant thinks about it. These are publicly traded companies typically. Um, but if I were them, I would think about it as my competitors are doing this. It engenders a certain amount of goodwill in the community. It also becomes a bit of an expectation to a certain degree, even though I think we suffer from like a massive awareness problem with 501(r). So I would probably put it as like it's kind of like branding, differentiation, or marketing. If I'm a
Right.
system, I'm like, it's a
I'd be
customer
fascinated to
expectation.
find out, because I'm sure it's not the heart function of a corporation that does it.
I
Engineers,
suspect, yeah. I mean, I
financial
suspect
aspects.
not. Like, yeah, certainly they have a mission at the center of what they do to a certain extent. I don't want to discount that, but I think they don't have a regulatory requirement to do so.
Mhm.
But so they must be living and dying by a business reason.
Yeah, from my side of it, seeing like the ridiculous reimbursement rates they request, regularly 4 or 5x Medicare, occasionally 16x, 18x Medicare. It's like, okay, so they're doing that on one end. Like, there's got to be a function, a reason for them to offer the financial assistance, because they're kind of blowing the charges up at the front end and then accepting financial assistance, of programs on the back end.
Yeah, I think I think that yeah, there's just kind of a necessity, and I can't say this because we've seen the data. Like an HCA, for example, not every single HCA institution, but certainly a lot of their hospitals, we've seen those machine readable files, which are the files that they have to publish, and
Hmm.
they are subject to this requirement to publish their prices. They're like think of like their MSRP, their charge master rates tend to be really high compared to even nonprofits. So I'm sure there's some amount of that of like they're simply not going to collect. They charge really high rates. I suspect most of the kind of like the network, like the health plan negotiator rates they have with large payers or carriers like an Aetna or Cigna or whatever might be off a percent of bill charges. So
Hmm.
either way, you're at the end of the day, you're dealing with a big number remaining.
So financial assistance, not for profit, a lot of for profit hospitals. So what we're talking about is the employee's cost share of whatever their claim is. What I was surprised about, what my clients are surprised about when I present how this works, is the amount of basically like income a household could receive and still qualify either for that partial uh, basically waived deductible or co-insurance, or full, right? So let's talk about kind of the income limits that are set on this 501(r) program and who's eligible.
Yeah. So yeah, first question is always, what percent of hospitals does this even apply to? We kind of covered that. And
Hmm.
most plans, like you mentioned, one client it was like all of the facilities
Hmm.
that their employees go to. We tend to see that. It's like 85 to 98% of the hospitals that they're seeing claims for are this type. So then the next question is what you're asking is, okay, but how applicable is this to my employee base? Um, there is no regulatory set limit, although we're about to see it, I think, because the U.S. Treasury just came out with a recommendation to the IRS saying, hey, you actually need to codify the actual eligibility requirements to at least establish a baseline. But when this came out, the American Hospital Association put out a memo saying, hey, I think we should probably all adhere to a eligibility framework that is a percent of the federal poverty guidelines. But we're going to use like a multiple, and that's what most do. So what you tend to see out there is most hospitals will phase out eligibility for this program at about 400% of the federal poverty guideline, which for 2025 comes out to just under, for like a family of four to index people, like 130 grand in household income. It covers a lot of people. I think that's probably somewhere around half of the country
Yeah.
would probably
Yeah.
fit
Huge.
there. Yeah,
So a
and be
family of four making under 130 grand would be eligible for partial, at least, of this 501. What's the proper term for the 501R program? Like financial assistance, I guess. Financial
yeah,
assistance.
it kind of goes by a bunch of things. We go by 501R because that's just that kind of like immediately differentiates it between something that might be like a for-profit financial assistance. But you can hear 501R, financial assistance, or charity care.
Mhm.
We tend to hear mostly the first two.
Okay. Yeah, I'll stick with 501R financial assistance, those kind of two, because this is at the end of the day, it's a government program that these hospitals have to offer. So it's like either the employees take that program or they have to pay it. Like it's there for use.
Right. Hospitals literally, so every single year, if you're a CMS registered hospital, which you probably are, most are, every single year you have to file a cost report with the government. And it's like, think of it as like, it's almost like filing your full accounting, like your financial books as a hospital.
Mhm.
And on one of those worksheets or one of those forms, there's a line item for how much did you write off under your financial assistance 501R program. And the hospital will write it off at cost. So yeah, they literally have to put a number in that value. And if they don't, that's not signaling very well to the IRS that you're justifying your tax exempt status. And then so the law requires them to make reasonable efforts, publish these things. So you're right. If people aren't using it, it's just sitting there.
Yeah.
When most people are entitled to use it, and thus
Yeah.
reduce the cost and burden of care.
I love this. I love this particularly for when we first engage with a new plan sponsor, because the first thing we're doing is kind of benchmarking costs. Like we're benchmarking their deductible versus their state versus their industry average, their premiums, the employees' percentage of that premiums. And often what we see when we get started is all those numbers are high, right? The employees' deductibles are high and their co-insurance is high and their share of the premium is high. And also what's left that the employer is also contributing to is high. So this program is something that you can put in day one and offer the employees a significant reduction. I mean, down to zero, hypothetically,
For
right?
some
In some
people.
cases.
Yeah.
Right. So this is just like an amazing program. And I know the first time I rolled it out, it was a new client we just started working with. Actually, we hadn't even started. It was part of our proposal because we had benchmarked that and we said, look, here's this program. Here's how many of your employees would qualify based off your census and like what I had. Turned out to be like 90% plus of them qualified. Also, it was one of those scenarios where they were all going to not-for-profit hospitals anyway. And the first thing they said is like, well, why didn't my broker tell me? And I was kind of, I didn't know, I honestly didn't know what to say, but what is your take on that? Why do more people not know about this? Why is this not part of everybody's conversation every single day?
It's a good question. Well, number one, yeah, it suffers from like a general awareness problem. I think that people are not aware of it because even if you were, again, we're a software company. What is our job? Our job is to make it easy for members.
Mm-hmm.
Because what we saw was that despite hospitals having the regulatory obligation to make people aware of it, it's kind of in direct conflict with their incentive to collect balances. Of course, they don't want to lose their 501c3 nonprofit status,
Mm-hmm.
but they're not incentivized other than that to drive it harder. Plans have all the incentive in the world, but it's kind of hard to make it easy for members to actually take advantage of. So without software actually reaching out to employees and saying, hey, let's take you to the hospital, let's screen you for this, and let's run you through the application. You can do it on your phone, etc. The status quo is you have to go to the hospital website. You have to navigate usually like 5 clicks deep. You have to find a PDF. Maybe they'll have an online form. Maybe. I would say the far minority. You have to get that PDF. You have to fill it out. Every single hospital has its own form. Like it's a bear. And so I think it suffers from an awareness problem. But even if you were to think about it, actually putting it into place before a product like ours existed was, I mean, I've talked to like literally like the 1 to 2 brokers that were doing this, and they had someone on their team manually doing it. But before that, it's just not even feasible. It's not practicable to actually get it done for somebody.
Yeah.
So
Totally.
that's usually what I attribute it to.
No, I'd agree. I mean, and that question kind of took me aback, but I mean, the only thing I could say is like there is no mode of compensation for, a broker in the traditional sense to offer something like this and to do all like there's no method of compensation. So it's just all additional work. Which is kind of why, unfortunately, it hasn't been rolled out, which is, I mean, it sucks to say, which is, why you're on today. So,
Yeah, exactly. Like I think if you don't have somebody doing it for you, it's, yeah, like you said, it's additional costs. It's eating into my margin. Like I can't do it.
yeah.
But
Yeah.
fortunately,
So
it
this is
exists.
a great program to get going because it's straight, it's for the employees, it's reducing their cost share. So there's a second aspect to this, which is also the bill review piece, right? So let's talk about that because there's, in addition to offering the employee something, building some goodwill and some trust as you try to change and adapt the healthcare plan for sustainable and predictable premiums. That's a great thing, but there's also a measure of some cost containment for the employer and for the plan as well under the bill review aspect. So let's talk about that.
Yeah, I think I'll kind of give you a little bit of like our origin and how we even got here because it kind of helps paint the picture. We actually started Goodbill direct to consumer of
Hmm.
like, you can be a consumer of whomever with a hospital bill, come to us and we'll try to reduce it. And we'll, again, apply any strategy possible. And we actually started with um, bill review, and I'll kind of like tease that apart a little bit. We actually built out direct integrations with think of like the my charts of the world where we could get medical record data. And then
Hmm.
we would go get the actual underlying claim and the itemized bill, and we'd marry all of that together to review the thing. And what we learned is we were seeing clear mistakes. Like this is not like super technical jargon. It's like, oh, that thing didn't happen, or the bill says it happened this many times, but it didn't actually, or that it was actually not as severe according to the medical documentation as what you're billing, et cetera. These things started to come out. We're like, well, why are these even here? Right. This is like someone who's insured, and that claim has in theory been run through some kind of machine. People or software has been run through some kind of machine. And I think we gradually started to see, oh, wait, no, that's actually not true. It wasn't, because these things are just being auto adjudicated. Uh, and so that's as we started to see that, we're like, oh, so just the state of the art in the industry is not such that these are getting the scrutiny that they need to get to ensure that the provider is reimbursed fairly and accurately, but the plan is paying fairly and accurately.
Hmm.
And so that is, yeah, exactly as we started to transition towards, okay, well, again, all of these incentives are most aligned with patients and their plans, which are the payers of all these services. We started incorporating bill review into it. And again, we're not trying to like pull one over on hospitals, um, and never trying to say something that is not justified. But we just simply ran into the truth is that this is not always done for various reasons we can go into,
Yeah.
but it's not always done.
I find that it's not done at all. The bill review and results that we've seen from bill review are just stunning. And also you start to see like how little care and effort your TPA, who may or may not be owned by, the insurance company and also be the network and the PBM and your healthcare plan, how little care they took to even have the data for these claims on file. I know we've gone through bill review for 6-figure bills and they don't have an itemized statement. It's like
Yeah.
you just paid a 6-figure bill and you don't even have an itemized account of what you paid. Like it was absurd. And when we finally got it, 6-figure bill, I think in that particular scenario, we're able to knock off like 18K in duplicate charges and,
Yep.
DRGs and individuals and all kinds of stuff.
Yeah. I mean, so we'll go a little like a layer deeper into why do we see these things? Number one, yeah, if you're on a plan where it's a large what I'll call carrier or insurance company, the way in which you review something should be a function of how that provider is paid. So like some contracts are a percent of bill charges, in which case it's literally like every single item is going to add up to a number that then your health plan will pay. I'm making a number up, 60% of that number. So naturally you're like, I really want to know, was everything right? Because at the end of the day, I'm paying for that. Versus some contracts are structured as like, we're actually going to bundle some things together and then put a price on that. So maybe the composition of the bundle changes, but I don't really care as much because I'm paying that flat dollar for that bundle. That's a much more sane way. But this type of information is typically like, oh no, that's a trade secret under the provider contract. I can't know that.
Yeah.
And then you don't know how to review the thing. And then if you do eventually do it, you run into what you ran into, which is like sometimes, many times, the claim is not being reviewed because also certain networks are scared of showing that data to hospitals and saying, actually, on this instance, you shouldn't get paid this much because this is wrong according to this policy. And if a carrier upsets certain health systems and hospitals, they don't have a product anymore. They don't have a network.
Yeah, you really start to untangle the web and what's going on with this. And what's shocking is one, not even having that information on file, how little care they put into it before they actually paid. And then also like they want to restrict plan sponsors access and ability to even do this kind of bill review, which is wild. Like there is no department in a company where you just blindly pay out accounts payable. And I mean, that's just not a thing. And then particularly like let's say you don't think you're doing it blind because you hired an insurance carrier, but everybody in that chain makes more money when the plan sponsor pays more.
That is a big problem, is that you've introduced a complex problem now, you've overcomplicated it, and then there's kind of like bites out of every layer. And then it is, like you don't even have access to it. And I think what we're seeing is more of a conversation around, wait, hold on, these health plans, employer-sponsored health plans, the plan sponsor, which is like a proxy entity for the employer, has a fiduciary duty to make sure they're paying the best rate possible, right? They're being good stewards of their money, like the plan's money, which is their money, and employee dollars. And so I think this type of conversation, this type of concern is only going to bubble up more and more as that becomes more of a concrete problem for employers of like, oh my God, just like a retirement or 401k, I hire somebody to manage that. I have to be doing the right thing. And I think we're at a point in our industry where there's tension between, I think, people like us that want to do the right thing. Employers are like, yeah, I think I'd like to do the right thing because it feels like I'm overpaying for a bunch of stuff. And then the perhaps asymmetrically powerful parties that be on the other side of the table, they're saying, I'm not sure I want you to do what you want to do because you're going to upset my apple cart and you're going to change the dynamics to a certain degree. I think we're starting to have that conversation as an industry much more than before.
Yeah. And I think this is a great example. So like one of the conversations I have and I repeat often is like the only role of a consultant should be, how do we reduce the frequency and severity of claims? And the second part of that conversation I have, because when I say that to a plan sponsor, often what they hear or what they're thinking about is like medical conditions. So they're thinking like wellness and different things, like let's not have the employees be sick. That's not it. Like this is a perfect example of understanding like a claim is a request for dollars for a covered incident, right? And what we're doing is we're taking that claim and saying, yes, covered incident happened. We're going to pay for that. But this claim is overpriced and there's duplicate charges and overbilling and upcoding and all kinds of other things going on. So it's not ever about, restricting employees access, putting them in tighter networks, increasing their costs. Like this is just one of those responsible functions that should exist. And I think most people would think it probably does exist, but it's just not happening.
It doesn't. Yeah. I think to your average consumer, anybody, they think this machinery exists and it just doesn't. And I think that's right. Everybody is, well, maybe not everybody, all we're trying to do, and I think everybody who's probably listening to this is like, yes, covered care, we will pay, we pledge to pay for that care.
Mhm.
Hospital or provider, I want to pay you for this care rendered. I just want to know what it is. And I want to see the receipt.
Right.
And that's it. And
Yeah.
at the magnitude of dollars we're talking, it feels like not an unreasonable request. Yet the intermediaries say that is an unreasonable request, which then obviously always begs the question of like, why? What are you afraid of me
Yeah.
just looking? Um,
So these are for I think another important to address is this is not employee facing, right? This is happening in the back end of the plan. This is something that's kind of written in the SPD. This is how the plan is going to operate. So can we talk a little bit about threshold for bill review? Maybe what percentage of bills you see with inaccuracies, and then what that percentage is in a dollar amount as well.
yeah. I guess the one thing I would say on that we have a different perspective on the whole back office versus employee facing is that usually in most of our customers' situations, these employees have cost share. Like they have a deductible, they have co-insurance. And so at the end of the day, they're kind of feeling the consequences all of these. And to date, their health plan or whatever has not really equipped them because the health plan itself has not been equipped to bring them into that equation in a way that is to their advantage. And I can't tell you how many times we've done a bill review or negotiation and a member has said, wait, oh, everything's right? I'm like, yeah, everything's right. It's right here in your medical record. Here's how it all ties together. And they're like, huh, all right, that's worth it enough. Thank you. I feel good now. Right. And that's it. So I think there's a lot of value to engage members. I think some people, some plans are still scared to do so. But by doing that, again, and also employees, like people, consumers, they have natural advantages to data that maybe a plan doesn't, like the
Right.
medical record. Like
Yeah.
one snap, they could grant that access.
Getting
So
you
that
like the EOB or
well, like what we do today, where we built out our MyChart integration. So if you're a
Mhm.
Goodbill covered member, you can connect your MyChart to Goodbill, and we'll instantly get your medical records, so that as you have a claim come in, we can review the thing. Whereas a plan would have to send a fax request to the hospital asking for that data. The hospital's going to take some period of time because they have no legal requirement to respond to the plan. I mean, the repercussion is they don't get paid, but we've seen that not necessarily be like a strong enough incentive, which is odd. Um, but members can do a lot of things. That's all I mean to say is like,
yeah.
there is a way in which all of this can be exposed to an employee to their benefit and everybody's benefit.
Yeah. And they
Um,
benefit on the reduction in cost share if they have, 10% co-insurance and you find
exactly.
some ineligible charges. Yeah. Certainly there's tons to benefit the employees. I think what I meant was just like from a punitive standpoint, like the solutions that most plan sponsors are used to is anytime something's, improving or we're trying to contain some costs or reduce exposure, like it's usually directly transferred over to employees in a negative way, you know?
Yeah. Yes. Yeah. Agree. It's usually like an exclusion or
Yeah,
yeah,
exactly.
I
Can't do
agree with
this
you.
now. Now, before you do this, you have to call, it's like, no, this is there for them and it benefits them in every way.
Yeah.
But it's not a punitive measure.
Yeah, exactly. So thresholds on bill review, we would kind of take a rule out of our direct consumer days of kind of like let the plan sponsor and or the member appetite dictate what you review and what you don't. I think uh, naturally people are going to care most about the things that everybody cares about, which is the higher dollar ticket items. We tend to see most people stop caring at about $500 and below. Like individuals, they just don't care. They're not going to go through any kind of process. Plans, I'd say it's like 1,000. So it's not such a differentiation there. When it comes to, so let's say we're taking all the claims there, what do we tend to see? It depends on the claim type, but overarchingly, we tend to see about half of them have something wrong with them as revealed by the medical record. So whether it be undocumented care, so it's just not present, so then you don't know whether it happened or not, or it's just the wrong number of things, whether that be something that is dependent on time, like, no, actually, it wasn't, I'm making this up, like 57 minutes, it was 28 minutes. And that actually matters a lot because that means you can't charge for this, you have to charge for this lower one. Some hospitals, again, we'll go back to paying things on a percent of bill charge. You then want to scrutinize every layer. And sometimes one of those items was really like a logical, natural component of another item where you couldn't do that other thing without this thing. So why are you charging me for both? Just charge me for one. Like my favorite is you'll get a charge for a lab, like a blood lab. And then you'll get a separate charge for the blood draw. And you're like, just charge me for the lab, man. Like, don't charge me for pulling the blood for the lab. That type of stuff. Then when it comes to actual, like, okay, how does that translate from like a bill charge perspective? You're typically seeing that, I'll just call it like around 20%. So you're finding something half the time, and the actual dollar impact is, think about like 20% of bill charges.
It's huge.
It's huge. It's massive, which is why it's like, number one, review the things. And then number two, if you can, structure your way out of needing to review the things where maybe you pay something on not a percent of itemized, a percent of billed. But again, now we're getting into like deep stuff.
Like the peace of mind, even for an employee, like they get this big bill, they look at it, and oh my God, I can't believe I owe that much. I thought I had insurance. And then they're trying to figure out this process. They're trying to, they want to know the same thing. Is this right? Is there some way I can pay less? Like just to be able to send that off to Goodbill in an organized function online, right? Get you guys integrated on your portal, and then just wait and have you come back and be like, actually, we were able to reduce it. Or even, you know what? Yep, that is correct. Like now, you're not being overcharged, and, you could start to take care of that bill, but hopefully we find some inaccuracies and we can reduce it.
Yeah, exactly. I think like I said, and it was actually one of our first, back in the day, 4 years ago, and it was just my co-founder, Ian, and I. We had one case that led to a discount. Then we had a second where, again, it was that like, hey, it's all right. And let me explain how it's right from both a billing perspective and a price perspective. And that person said, wow, I didn't understand it before. Much better place. I feel very good about it. I'll just pay it today. Can I pay you? And back then we were doing everything manually, right? No software. He said, I want to send you like a $20 Amazon gift card. We're like, that's really sweet of you. We're just learning. Like, no, but there's something there, right? Where there's value in just knowing that, number one, they learn something. Number two, they feel confident. And number three, they feel like it's transparent. And I think that's where we are going to be getting to as an industry, is make people understand that they can see exactly what happened. Because if they can't, immediately there's doubt. And then they can feel better about paying something if they do have to pay something. As long as it's fair and transparent, I think you're going to see a shift in how people think about the cost of care. Today, that just so happens that it's neither of those things.
I mean, the employee advocacy of both these programs together is just unmatched to help them understand, the finances of healthcare and the affordability of it. Having a resource to vet these things through, walk you through 501R financial assistance if you can. If not, understand your bills and make sure those are accurate, remove any inaccuracies. It's such an awesome measure of trust building, communication, advocacy for the employees, with some real time results for them as well.
Yeah, exactly. And I don't think we're going to be getting away as a country from cost sharing, deductibles, co-insurance, right? There'll always be that kind of cost split. So as long as there are real dollars at stake, people deserve to know what's going on.
Especially with this trend of HDHPs and
right,
like that's all on the employees right away.
Exactly. And employers are not going to give those up because it allows them to reduce a little bit of their cost because they're bearing most of the premium in most cases.
Let's talk about, for the employers listening, this is awesome. I think this is a no-brainer. We use it. It does work. I love it. What a trust building, tool to implement your healthcare plan. But let's talk about like implementation, integration, maybe with carriers, kind of those things that we need to know to actually put this into effect.
Yeah. I'll go kind of like best case and then settling case. Best case, we're usually integrating straight with a third-party administrator to get claim feed rolling and eligibility rolling, which means we know who people are and we see when they go to the hospital, which means that people don't need to remember us other than to remember the name Goodbill, and they may or may not reach out to you if you go to the hospital, but then we get to be very proactive. And that is kind of a delightful moment for some members where they're like, wow, whoa, my plan, we've also triggered our workflows off of prior auth feeds, which means we've caught people literally in the hospital bed. And some people, not all, some people are like, hey, I've got downtime. Whoa, I didn't expect my plan or like an arm of it to reach out, but yes, I would like to screen for this program and apply. I'll do that right now. Um, so that's kind of like best case is we have data coming and it allows us to be very proactive, drive engagement, drive results, and then reduce the load on employees. The second is maybe you're in like a fully insured plan, and if you go to Cigna or Aetna or a Blue, they're going to say like, no, I'm not giving you claims.
No
I'm
way.
not giving you, yeah, right. Then we arm every single layer of this, right? Donovan, yourself, you and your team, the employer, the HR team, the HR lead, down to employees, with everything possible to remember. If you get a hospital bill, you're not alone. You can go to goodbill.com/whatever personalized website we have for you, and just one click add it there, and we'll take care of everything else. So you can put this in any kind of environment. We, of course, would love to get, most of our clients are on the integrated path where we can just make it something that runs in the background and we'll reach out when we need to. But it'd be pretty straightforward.
Yeah. I love it. And another thing that I really like about the program is the timing. So this could be a past hospital bill that, maybe employee has not paid all the way or any of it, and they're trying to get that mitigated. Or it could be something that, they fill out 501R this year and then they happen to go back to the hospital. So let's talk about kind of those timing guidelines of past and future.
Yeah. So 501R has many really fun things other than an initial discount, which is many hospitals, I would say most hospitals, if you're approved for their 501R program, they will give you a duration of that approval, right? People's financial situations, they change, of course, but they don't often change that frequently within a given year. So you might be approved and that approval is good for like 6 months, 9 months. So if you go to that same hospital or health system for subsequent necessary or emergent care, you're going to be discharged and you're going to get that approval and you'll have no balance or have an immediately reduced balance. The second thing that's really cool about it is if you've already paid a bill and you paid more than $5 and you apply within a certain window, within 240 days of whenever you got the first bill and you're approved, the hospital is required by law to refund you. So like for anybody out there that has spent more than $5 on a hospital bill that you think might qualify for this and you're within that range, you should just simply apply and see what happens, because you could get your money back, all of it. And then if you're approved, it comes with other things too. If you're approved and you have an unpaid balance, they can't send you to collections. They can't sue you. They can't ding your credit score. They can't deny you future care because you have an outstanding balance. Like there's all these other things, because you can see the spirit of the law is let's protect patients. And it really does a decent job of that.
Any kind of closing thoughts or anything I didn't cover that people listening to this and thinking like, how did I not know about this? Like anything else they should kind of know about the solution or implementation, getting it started?
No, I kind of view it as like, of course, I'm very biased here. Every plan should have this. I frankly think we're the best at what we do, but every single plan should have this. I think increasingly becomes a bit of a fiduciary thing of making sure you're taking care of members. Of course, if you think 0% of your employees would qualify under this type of rubric, fine. But naturally, I think everybody should have it. And it just gets people thinking more about questioning, I think, their status quo of, am I really looking at everything I should be looking at? Am I doing everything I possibly can to manage these costs? Because it's now becoming increasingly like the number 2 line item for any business, certainly for employees.
Yeah, I think particularly if you're in a plan that's restricting your data and you don't know what's there, like this will give you some insights, and it'll give you insights to the very largest bills, because that's the ones that your employees are going to be most concerned with, and get over to Goodbill, and then you get to see kind of, wow,
What
like
happened?
there's that much like waste and abuse in that invoice. Like what the heck else is going on in my healthcare?
Right. And now you can start to have some kind of data for some kind of conversation, whether it be on a renewal or mid-year. So
I agree.
agreed.
I agree. Well, thank you, Patrick. I think I'm sure you opened up a lot of eyes today. This is something we use, like I said. I think for certain employers, depending on salary range, it's a absolute no-brainer. And then I think for most other companies, it's just a really great idea. I think a lot of industries should just absolutely have it no matter what. And then for most others, it would just be a really good measure of cost containment and advocacy just on the billing perspective, even if they, reasonably nobody's going to qualify for a 501R because they're all, professionals or whatever, white collar professionals. Like they probably they almost definitely don't want to look at a hospital bill and check it for accuracy in that case. And
Exactly. We've seen a lot of people, private equity folk, like we're a venture backed startup. We had investors use us, not because they would qualify for 501R, but rather because they have that exact problem of like,
Yeah.
man, this is expensive.
Yeah.
Why? And I just want to know more. And if I can get a discount, that feels right. So yeah, fully agree with that. Thank you for having me on, Donovan. Like always good to spread 501R. Again, even if it's not through us, like put 501R on your plan.
Absolutely. Where can people find you if they want to find out more?
Always goodbill.com. If you want to email me personally, it's patrick@goodbill.com. Easy.
Sounds good. Thanks, man.
All right. Thanks.